Good evening, everyone. Welcome to another session of the weekly huddle. Today we are at session 134. I am Dr. Praneeth. I'm a consultant cardiologist working at KIMS, and joining me is my colleague and co-host Dr. Anoop Agrawal, who works with me at KIMS. We take this session to discuss clinical situations and trying to understand about the practical aspects of it, understanding how each and everyone will have their own practice patterns and learning from each other. And today's session we are discussing about one of the common clinical scenarios about managing patients or having coronary artery disease and coexistent chronic kidney disease. Diabetes is quite prevalent in India, and diabetes is one of the important risk factors for chronic kidney disease, and so is the risk factor for coronary artery disease. And many patients have coexisting two conditions: the coronary artery disease and chronic stable angina. When there is progression of chronic kidney disease, most of the drugs that we give for management of coronary artery disease or be it other issues, they it becomes challenging because some of the drugs needs to be modified or sometimes have to be stopped because of the worsening renal function, which can probably have an impact on the other disease that is coexisting. So one of these clinical situation is makes it a bit challenging to manage, which I want to discuss. Which I have equally had a case, and we'll try to discuss this thing. And to facilitate the discussion, we have an expert. We have Dr. Sindhu, who is a consultant nephrologist working at KIMS Gachibowli. So she will be helping us help understand the nitty-gritties of managing patients with chronic kidney disease. So I'll start discussing about the case. I'll give you the case details and take opinions, and then Dr. Sindhu can help us understand how to manage it better. So this patient whom I'm seeing in my OPD is a 65-year-old male who has a history of hypertension and diabetes for about 10 years. And he's been following with me for the last couple of years. He started complaining of exertional angina for the last 6 months. Because of his typical description, I made a clinical diagnosis of chronic stable angina, and I've advised him for medical management of stable angina. So he's kept on a single antiplatelet therapy, statin, and at the time his pressures were slightly on a higher side, and equally his heart rates were slightly on a higher side. So I modified his antihypertensive medications. He was earlier only on telmisartan, so I added a chlorthalidone for better control of his blood pressure. He was also on a combination of spironolactone and torsemide. So because he was on that, I stopped his torsemide because I couldn't find any reason he was taking torsemide. But I continued spironolactone low dose because it was helping him manage his hypertension as well. I've added a beta blocker and a nitrate. And for his diabetes, he was taking a combination of glimepiride metformin combination and teneligliptin and metformin combination. And he was doing fine. He responded to the treatment and he was on follow up for the same thing. As a routine checkup, because patient is on multiple drugs and his diabetes and hypertension status, you ask for routine labs. So normally he gets it done at his local center. So I asked him for a kind of an investigations done in a more reliable lab. So this time he comes with his master health checkup, which he got it done in one of the reliable labs, and he comes back to follow up with the reports. From symptom point of view, he's otherwise fine. He doesn't complain anything. He is just a retired employee, and he does his regular activities. He does his 30-45 minutes of normal walk, and he's able to carry on himself. So when I looked at his reports, most of the reports were otherwise fine. The most important striking things were his creatinine, which has increased from 1.8, the last that I saw close to 6 months back, to 2.5 this time. His potassium was 4.9, and hemoglobin was 9.8, which was normocytic, normochromic anemia, and the rest of the other parameters are okay. Most of the labs are fine. If there is anything else that you would like to know, please you can please ask me. I can provide this information. So main concern that this patient had is because of one of the relatives who is into medical field, and also by his search into internet, he's worried about this creatinine, which was highlighted in bold in the investigation report, and he tried to do some of his own research, and he's worried about his creatinine being elevated, and is concerned about the drugs that are being given, and he understands that some of the drugs are contraindicated in um, kidney patients or those who are having increase in creatinine, and is equally worried about him progressing into kidney failure and whatnot. So this is this patient who comes up. So he was asking specifically whether he needs to change any medications and what medications to be avoided, etc. So these are the set of questions that he had in mind, and those are the same questions which are the focus of discussion today. So for a patient who has a recent rise in creatinine, who is otherwise stable, where he is non-oliguric and he doesn't have any symptoms or signs suggestive of any acidosis, how do we manage these patients? So patient who is taking RAS blockade drugs and mineralocorticoid agents, how do we manage these patients? What is the take on them? And uh, patients who are on kind of moderate to high intensity dose of statins, do we need to modify their dose of the drugs? Again, understanding that these are important drugs for coronary artery disease management. And the patient who is receiving metformin for management of diabetes, do we need to modify the dose of metformin and other uh, diabetic medications? And patient also seem to be having anemia. Technically, it's not a severe anemia, but from coronary artery disease point of view, it is still an anemia which can aggravate ischemia. So how do we manage anemia? What are the targets for patients who are having chronic kidney disease? And in case if this patient needs any intervention, if not today, tomorrow, because the disease is progressive, and if he needs an angiogram, how do we plan when this patient is having chronic kidney disease with increasing creatinine? So these are the questions which I had in my mind. So this is what I wanted to discuss. So maybe I'll start with Anoop. Anoop, if you were seeing this patient in your OPD, what are your initial thoughts, and how would you answer the questions which are raised by patient and the questions that I have in my mind?
So, Praneeth, few things which strike to me. Number one, that we are saying creatinine has risen from 1.8 to 2.5 because labs have not been checked in the last 6 months. I don't know whether the rise is acute or whether it has been a slow uptrend, which is very much possible in a patient of this with this kind of comorbidities where the CKD might just be rapidly progressive. So just the routine stuff that we all do whenever the creatinine is high, we always make sure we check for urine if there is any UTI, if there is any blood, if there is any suggestion of kidney stones. We look for ultrasound of the kidney, ureter, and bladder to look for any hydronephrosis, any pyelonephritis. I think it can be combined with a PVR where you can look at if the patient is emptying the bladder completely, if there is any dynamic problem and those kind of stuff. So I think that is a good starting point to start with at least the urine analysis as well as ultrasound. My gut feeling is that this is probably a progression of CKD rather than an acute or chronic, because typically in acute symptoms, in acute scenario, we do see some sort of urinary symptoms. There are typically precipitating factors, and many of the times you see hyperkalemia. In this particular case, where the potassium is quite reasonable, and with his anemia and everything, it kind of just fits into the picture of progressive CKD rather than an acute or chronic. Having said that, I still will test him for any acute precipitants, and simple doing urine analysis and an ultrasound are a good place to start with. Now, He does have coronary artery disease, which has never been evaluated. So a patient who has never had a coronary evaluation done, while the medical management is good, I still don't know the anatomy. So I don't know whether the patient has a high risk anatomy, whether the patient has a low risk anatomy. The data in stable angina symptom has not been quite promising in favor of invasive assessment. Having said that, there is some school of thought which is still not refuted that patients who have got high risk anatomy may benefit from an elective angioplasty. In this particular setup where the price we may have to pay is worsening kidney disease, that decision needs to be taken quite with lot of discussion. I think that is a decision we can't just take at the drop of an hat. So I wouldn't do an angiogram on him, but I certainly would like to risk stratify a little bit with the tool which won't hurt his kidneys. So that is my thought about his coronaries. As far as your questions are concerned, so the use of RAS blockade, I can't remember on top of my head, but I vaguely remember reading about it a few months back, where RAS inhibitors are okay to be used till the time we can manage hyperkalemia. ACE inhibitors may be a problem. That is what I recollect in end-stage renal disease patients, not particularly CKD stage 3 or stage 4 patients, but those who are stage 5 or those who are on dialysis. There, I believe RAS inhibitors, ARBs probably are better choice than ACE inhibitors. That is what I vaguely remember reading about it. Mineralocorticoid antagonist can be used for hypertension management, but anything other than hypertension, I particularly don't think there is any role of spironolactone or any mineralocorticoid antagonist in angina management or in CKD management or anything else. Now, this patient doesn't have heart failure. Otherwise, that could have been a situation. But anytime we talk about RAS blockade or MRA, we have to make sure that we are working with potassium levels. I particularly don't feel comfortable giving spironolactone in anybody with a creatinine more than 1.5, unless they directly go for dialysis, where I know the potassium has been taken care of. The dose of statin, I really don't have any problem, and I believe nephrologist can probably give us more insight. I don't have a problem escalating high doses of statins in these patient subset. So regardless of the CKD status, I give them statin dose, which I feel is required depending upon their cardiovascular disease. In most of these situations, giving a high dose or a high intensity statin will be my approach in this patient. Diabetes medication, metformin, I think there are consensus statement which says metformin in a creatinine more than 1.5 should be judiciously used. I typically do not use metformin in people who have got creatinine of 2 or more. That is what my thought is. Between 1.5 and 2, I become a little bit skeptical. So this patient is on 1,000 milligrams, no, 1,500 milligrams of metformin. I think with this creatinine of 2.5, I'll just take metformin out completely. In fact, I become a little uncomfortable with sulfonylurea as well because of their clearance. And these patients, they run the risk of developing hypoglycemia. But continuing sulfonylurea cautiously is not a problem. I definitely would take metformin out. On the same line as SGLT2 inhibitors, I do not think there will be any role for this. So that is also something you can take it out. He's on tenligliptin probably, which was started before sitagliptin became very readily available in India, or linagliptin became very readily available in India. So these days, I'm actively switching patients from tenligliptin to sitagliptin or linagliptin, which are more robustly tested, and there is good FDA data to back up. So I'll continue sulfonylurea. I'll continue the DPP4 inhibitors in terms of linagliptin and sitagliptin. I will not give metformin. I will not give SGLT2 inhibitors. If that doesn't serve his diabetes requirement, then I will consult endocrinologist to talk about insulin and whatnot in this particular patient. Managing anemia in CKD is very challenging for me. Anything more than 10 is okay for me as far as angina is concerned. I know that managing anemia, particularly non-iron deficiency anemia in CKD, is quite challenging, and I truly speaking leave it on to the nephrologist to decide. As far as coronary artery disease is concerned, I would subject him for a SPECT scan. It can be either a stress spect, exercise spect, or adenosine spect, either of the two. I will put him on that, and unless the stress scan shows that there is a large area of pattern, there is a large area of reversibility, which I would say anything more than 10% of the total myocardium, I would continue medical management on this patient. I wouldn't think of coronary angiogram unless nephrologist thinks that his chances of requiring dialysis in the next 6 months is very high. In that case, I will subject him for angiogram if SPECT comes positive. Otherwise, I will subject him for angiogram only and only if SPECT comes very high risk. That is, if there is transient ischemic dilatation or if the myocardium involved is more than 10%. One more thing about his cardiac medication, he's not on calcium channel blocker, dihydropyridine calcium channel blockers. I definitely would put him on something like amlodipine or cilnidipine or something, because that will help with his hypertension management as well as with his angina management. That is something which I definitely would do as far in line with his medical management. So those are all the things that I would do, Praneeth. If something I didn't answer, you can please question me back.
Yeah, so your points are well taken. The follow-up of the questions that you asked, so in the master health checkup, he also underwent a urine analysis and ultrasound abdomen. So the urine analysis again did not show any signs of infection. He had 1+ protein in his urine examination, and the ultrasound abdomen again was unremarkable. He did not have any major issues. So the evidence of urinary tract infection or obstruction was not there. Your points are well taken, where you are okay continuing high intensity statin, stopping metformin, and equally stopping spironolactone is fine. So I concur with most of the points that you mentioned. Maybe I'll take one more opinion. I'll take opinion from Shankar sir, and then I'll come back to Dr. Sindhu. Shankar sir, what is your take on this patient? How would you manage this patient, sir?
Good evening to all. This is a very interesting case where we see diabetes, hypertension, and cardiovascular disease. It is an ominous triplet, what we say in clinical practice. So here many drugs, what he is taking should be changed according to my clinical. So in chronic kidney disease, if statin is essential, we go for only atorvastatin, especially in kidney disease. Rosuvastatin is associated, though it is a good drug, it reduces LDL more, but in kidney disease, we prefer only atorvastatin. Because rosuvastatin is associated, head-to-head studies were also done, where we found there is a hematuria, proteinuria, and progression of the kidney failure. So here, rosuvastatin has to be replaced by atorvastatin, one. And second thing is, this patient has got a serum creatinine enough for 2.5 and 65 years old. According to the equation, his eGFR is 28 ml per minute. That means he comes under stage 4 kidney disease. So when the in this situation, when the serum creatinine is around 2.5, in my clinical practice, though some nephrologists they still continue, but in my clinical practice, I stop telmisartan, ACE inhibitors or ARBs, and I shifted to cilnidipine or benidipine. So cilnidipine, I prefer to add instead of telmisartan, cilnidipine will give. And if the patient needs MRA, in this case, spironolactone has to be replaced by a new molecule has come into the market as a Kerendia. That is a finrinone. So this is many studies they prove that it retards the progression of the kidney disease. So the Findrinone 10 milligrams, because here the eGFR is 28 ml. So where we give Findrinone 10 milligrams per day. Then third one, regarding the diabetes management, teneligliptin, though it is found safer, but a patient is having cardiovascular disease where this teneligliptin, it doesn't have any robust cardiovascular safety. There is a QT prolongation is there associated with the teneligliptin. So in that view, I prefer the DPP4 inhibitor linagliptin. Linagliptin 5 milligrams can be given in all the stages of the kidney disease, the dose being unchanged. Whereas sitagliptin or vildagliptin, if you give, the dose has to be changed. The dose has to be reduced. But linagliptin in all the stages can be given, dose unchanged, linagliptin 5. So teneligliptin, I change it to linagliptin 5 milligrams per day. So glimepiride, as the Dr. Anoop Agrawal has already mentioned regarding the glimepiride. So here still the SGLT2 inhibitors, the DAPA-CKD or Emperor trials and all, they prove that earlier the SGLT2 inhibitors were not supposed to be given when the eGFR is less than 45 ml per minute. But the recent studies, they show that even eGFR falls below 20, up to 20 ml per minute, the SGLT2 inhibitors can be given, and they are renal protective and cardiorenal protective. Cardiac protection also will be there with the SGLT2 inhibitors. So here I add DAPA or empagliflozin instead of glimepiride. So metformin is out, as already everybody knows that, because the maximum dose of metformin in non-kidney disease patients is 2000 milligrams per day. But when the eGFR falls up to 45 ml per minute, the dose of metformin has to be reduced to 1000 milligrams per day. But when the eGFR falls below 45, up to 30, below 30, then there is no there is no, we don't prescribe metformin if the eGFR falls below 30. Here, already it is 28 ml per minute. So there is no role of metformin in this case. So coming to this anemia, there is a KDIGO guidelines are there. Kidney disease improvement, improving global outcomes, that KDIGO, everybody, nephrologists and physicians, although they follow the KDIGO guidelines. So there is a lot of literature is there on KDIGO guidelines regarding the anemia. So here in females, the hemoglobin has to be raised to 12 milligrams, 12 grams per day, and 12 grams per deciliter. And for males, more than 13 grams per deciliter. T saturation should be more than 30, and the ferritin should be more than 500. So these are the guidelines. According to that, whether oral preparations to be given or IV iron preparations to be given, that will be decided. But here it is only mild. We can give oral preparations. But in my clinical practice, Dr. Sindhu will enlighten this ferric pyrophosphate. Especially I give to my renal patients this ferric pyrophosphate. Especially even it will be useful in the dialyzed patients also. So ferric pyrophosphate, it is freely available in the market also as a Socril. So This is regarding my approach. So I change it to atorvastatin. I add cilnidipine instead of telmisartan. Then instead of spironolactone, I give fenrinone. Then teneligliptin has to be shifted to linagliptin. Glimepiride has to be dropped, and in that place, we can still give SGLT2 inhibitors, either DAPA or EMPA. Then metformin, no metformin, and ferric pyrophosphate in this case. So diabetes mellitus, hypertension, and CKD. It is ominous triplet. So where in order to retard the progression of the CKD, considering the diabetes and the hypertension management. So these are the changes to be done. I will be very happy if I'm enlightened by Dr. Sindhu, nephrologist. Thank you, one and all.
Sir, have you prescribed fenrinone to any of your patients, sir?
Yeah, recently we have started in diabetic kidney disease. It's a wonderful drug. Not only retards the progression of the kidney disease, but initially there will be a slight rise in eGFR, but we should not get worried. But it is a wonderful drug. It reduces the fibrosis of the kidney. That is the wonder. It reduces the inflammation and fibrosis of the kidney. It is a wonderful drug, fenrinone. Many trials are there. So this will be very much highlighted by Dr. Sindhu.
Yes, sir. So
it is available as Kerendia in the market by Bayer.
Okay, sir. Thank you, sir. Thank you for that information. So I'll come to Dr. Sindhu. Ma'am, I have a few questions. So firstly, when we talk about chronic kidney disease, what we read in textbooks versus what we practice, I feel there is some discrepancy. Most of the times what we read is in relation to eGFR. But in practice, the terminology is more in terms of creatinine. Is it that I alone am seeing that eGFR is not being that commonly used, or do we use, what are we missing here, ma'am? How do we assess the chronic kidney disease status, and how frequently should we depend or make the decisions based on eGFR?
Good evening to everyone. Thank you, Dr. Praneeth, sir, for giving me this opportunity. Am I the only nephrologist in this group now?
Yes, ma'am.
Okay, fine. So, Dr. Anoop and Dr. Shankar, sir, have almost enlightened us about most of the aspects. So I would like to go point by point. This patient, 6 months back, his creat was 1.8. Now his creat has increased to 2.5. So his GFR has gone down from stage 3A to stage 4. So any creatinine raise, which is significant, like more than 0.3, what we usually see in clinical practice, like Dr. Anoop sir said, any raise in creatinine, we usually see whether there is any pre-renal cause, whether there is an intrinsic renal cause, whether there is a post-renal cause. So patient might not be having any symptoms, but we have to think in all these aspects, whether his raise in creatinine is drug-induced, whether he's taken any painkillers, any indigenous medicines, whether it's any dehydration, whether there is any infection in the body anywhere. It can be an UTI or any pneumonia, and whether any recent change in medicines, also one thing. So before thinking it's a natural progression, we have to make sure that we are ruling out all these things, make sure that he is not having any infection, he has not taken any painkillers, he is not dehydrated. Now this patient, because we have seen certain patients who just come with raise in creatinine, and when we get an ultrasound, we have seen significant big stones causing obstructive uropathy. They're totally asymptomatic. Sometimes they don't have any loin pain, any fever, any UTI symptoms. Just raise in creatinine is the only thing we see clinically. So like Anoop sir said, yes, we have to evaluate whether there is any urine infection, and ultrasound is basic thing to see whether there is any obstructive pathology. Now coming to second thing, this patient, if his LV function is fine and he's clinically dry, maybe I will stop the diuretics. Like he's on chlorthalidone and spironolactone. If his LV function is fine, and if cardiologist tells that his ejection fraction is fine, his LV function is good, he's not having any breathlessness, no crepitations, no pedal edema, I will definitely stop diuretics. And like Shankar sir said, I will definitely stop telmisartan. and metformin and wait and see before introducing any new drug. I would first like to stop any culprit drug which can cause rise in serum creatinine. Wait for 1 week, wait for 10 days, 2 weeks, and see whether the creatinine is improving, because sometimes this dehydration, ARBs, they do cause rise in creatinine. So sometimes when we stop this drug, the creat might go back to baseline. Like in this patient from 2.5, it can go back to 1.8, but that only time will tell. When I find no other reasons like any obstructive pathology or any infections, I just stop any drugs which I think can worsen the creatinine. We sometimes stop those drugs before introducing any new drugs like any SGL. In this stage, at this time, I will not recommend introducing Finrenone or SGLT2 inhibitors because there is a race. So we'll first stop Telma, we'll first stop diuretics, rule out all the other pre-renal, intrinsic, post-renal, like I just said, and then reassess him. And like if creat is stable, it is not coming down even after 10 days or 2 weeks, maybe like Anoop sir said, it might be a natural progression. Because sometimes in diabetics, they can get non-diabetic kidney disease anytime. So they can get an interstitial nephritis, drug induced. They might get a glomerulonephritis, infection-related glomerulonephritis. So always the CUV is also very important. In this patient, you have not mentioned about his proteinuria. So what is his proteinuria stage? Because like you have asked, so any CKD patient, we see 3 reasons. What the KDIGO says is we have to label him as CGA. C is the cause of CKD, G is the glomerular filtration stage of CKD, the EGFR, and A is the albuminuria stage. Sometimes only urine, sometimes it can show that urine has become active. The previously inactive sediment, now urine sediment has become active. The proteinuria has increased significantly. So sometimes there might be some non-diabetic kidney disease going on parallelly. So any rise in creatinine, first we have to assess in all these aspects, stop the culprit drugs, and then reassess him and then reintroduce after some time. Like Shankar sir said, yes, definitely we can stop Telma and give him calcium channel blockers like cilnidipine and benidipine, which have antihypertensive effect and antiproteinuric effect, whereas amlodipine helps only with BP control, whereas cilnidipine and benidipine we can use in any stage of CKD, and they have antihypertensive, antiproteinuric, and less chances of edema. So this is first thing. Then regarding your first question, the mineralocorticoid receptor antagonist, yes, like Shankar sir said, Finrenone is the new kid on the block. It's a non-steroidal MRA, mineralocorticoid receptor antagonist. It has both cardiac and renal benefits. The Fidelio DKD study, it has shown it is anti-inflammatory, anti-proteinuric, reduces fibrosis. It's now available in India as Care India. It comes as 10 mg and 20 mg tablets. So we introduce it till your GFR is more than or equal to 25. So anything stage 1 to stage 4. So we can use this drug, but like we have to be careful, like if patient is already on an ARB, then we have to be careful when we are starting this because it can cause hyperkalemia. Any 2 drugs which can cause hyperkalemia when we are using in a patient, we have to be careful while we are monitoring potassium. And this is started as 10 mg OD, and we reassess the patient after 4 weeks to see any GFR change, any hyperkalemia. If he's tolerating well, we can increase it to 20 mg per day. And regarding the steroidal MRA, like your spironolactone and eplerenone, like Dr. Anoop sir said, yes, usually if there is an underlying heart failure or a refractory hypertension, these are the common indications from a cardiologist side where you put this spironolactone and eplerenone. And we generally, from nephrology point of view, we don't recommend using those drugs once your GFR is less than 30 because of risk of hyperkalemia. Then regarding the diabetes medicines, yes, like Dr. Shankar sir said, metformin is usually the first line of therapy. KDIGO also recommends the same, KDIGO 22, the latest guidelines. Once your GFR is less than 45, they recommend reduce the dose. And once your GFR is less than 30, discontinue the drug. In dialysis, anyhow, we are not going to use it. Then regarding SGLT2 inhibitors, yes, now as per the latest guidelines, we can use SGLT2 inhibitors if the GFR is more than or equal to 20. So up to 20 GFR, we can use the SGLT2 inhibitors. But the problem is, like you said, sir, all our patients are not having only diabetes or only hypertension or only CKD. They're usually having multiple comorbidities. So usually from nephrologist point of view, we don't recommend introducing diuretics or ARBs at the same time. We go step by step. First give a diuretic, then the ARB. Like the same time when we are introducing SGLT2 inhibitors also, we don't start everything on the same time, because SGLT2 is an osmotic diuresis. It can cause dehydration. So if you are giving diuretic and at the same time starting SGLT2 inhibitors, there are very good chance. We have seen many patients with acute kidney injury. Don't start ARB or SGLT2 inhibitors at the same time. Or we have to just prioritize which is more important. Like patient comes in heart failure, my first priority is to decongest him. Okay, just let me start diuretic, give some break, then reassess him, then give ARBs, then SGLT2 inhibitors. Because with all these drugs, like Shankar sir said, with your Finrenone or SGLT2 inhibitors, initially there will be some, even with your ARBs, telmisartan or AC inhibitors, you'll have a transient decline in GFR, which is like there are certain limits. Like if you start an ARB or AC inhibitor, up to 30% your change in raise in creatinine is acceptable. Anything beyond 30%, we have to stop the drug. At the same time, when we start an SGLT2 inhibitor also, we expect a change in GFR, like around 20% decline in GFR, around 4 weeks is expected. So we don't start higher doses. We go in incremental doses, we reassess them. And it is very important that when we are starting such drugs, we are sure that patients do come back for follow-up. Sometimes when they don't come back for follow-up, it will be very tough, because all these creatinine raises are usually subclinical. They might not have any symptoms. So this is one thing we have to keep in mind. Yes, tenligliptin we use till stage 4. So in this patient, I will stop metformin. Glimepiride we use till stage 4, but less than 15 GFR we can't use. The two drugs which we can use across any GFR, one is linagliptin, like Dr. Shankar sir said, any stage of GFR, no renal modification, even on dialysis, linagliptin 5 mg OD can be used. And even glipizide. Glipizide is 1 sulfonylurea, where we start from 2.5 mg BD to 5 mg BD. This is also 1 sulfonylurea, which can be used across any stage of GFR, even in CKD stage 5. So coming to your next question, is EGFR estimation, sir? Yes, we use CKD EPI. All nephrologists, we regularly use CKD EPI formula. And this formula is used when patient is in a stable condition, not when there is an acute rise in creatinine. So this is not the formula for AKI. So we use GFR when the patient is in a stable condition. And regarding statins, yes, like Dr. Shankar sir said, atorvastatin is the drug of choice, because atorvastatin is, the mechanism is CYP3A4, so it's a hepatic elimination, whereas rosuvastatin is renal elimination. So usually when there is an underlying CKD, it's not that we don't use rosuvastatin. More than 50 GFR, when cardiologists start rosuvastatin, we don't stop them. But like any statin, irrespective of your underlying CKD status, when you're starting a dose, we need to monitor their LFT and CPK after 2 weeks or 4 weeks to make sure that they are not having any side effects, because how the kidney function worsens related to statin is rhabdomyolysis and kidney injury. But otherwise, like sir said, atorvastatin is drug of choice. And like Anoop sir said, yes, even patient has ACS or already has an ACS and STEMI or STEMI has undergone intervention, cardiologist will start on 80 mg statin. It's never like we don't stop it. If patient tolerates it, if a patient needs it from cardiac point of view, we don't stop it. But yes, I do recommend monitoring, because we have seen severe myalgias, myopathies, and it's sometimes difficult to predict clinically that who will develop this side effect. So usually after starting, maybe after 4 weeks, we better ask them to do one LFT to check their SGOT, SGPT, and one CPK, or tell them to report early if there is any myalgias or extreme weakness, because I've seen few patients who had generalized weakness, and when we did CPK, it was like rhabdomyolysis. They might not tell only proximal muscle weakness or something like that. They can have generalized weakness. So especially when we are starting high dose of statin, monitoring is better. And regarding the intervention, yes, like sir said, Anoop sir said, if patient is stable from your cardiac point of view, you can manage him medically without any intervention, go medical management, because contrast nephropathy is like a most common discussion we have with cardiologists before doing an intervention. So any contrast nephropathy, the thing is, I am just reiterating the things which everybody knows, patient related and procedure related. If it's an arterial contrast, it is more risk. If you're using more volume of contrast, it's more risk. And if patient is hemodynamically unstable, your patient is already having an AKI, because we use this Meheran score for post-PCI contrast nephropathy calculator. So it also asks the same questions, whether the patient is in hypotension, whether the patient has any intra-aortic balloon pump, whether the patient is in a congestive heart failure, whether he's anemic or diabetic, and what is the volume of contrast used, because these all indicate the hemodynamic instability. The more and patient risk factors, diabetes itself per se is a risk factor, and CKD is itself a risk factor. So we assess. Sometimes when they have an ACS and cardiorenal syndrome, where the worsening of creatinine is secondary to your cardiac dysfunction, sometimes after stenting, once the cardiac function improves, we have seen that kidney functions also improve. So it's a, I think it has to be individualized based on patient to patient and patient risk factor. Because what I usually tell patient is, अरे यार अगर किडनी को कुछ हुआ तो हम डायलिसिस कर सकते हैं, हार्ट का तो कोई ऑप्शन नहीं है, you have to go for stenting. And regarding anemia, the targets are, it depends whether the patient is not on dialysis or whether the patient is on dialysis. So what our guidelines, what all nephrologists routinely follow is, any anemia we see, we first evaluate. We do B12, folic acid, complete iron profile, like Shankar sir told, iron, TIBC, ferritin and all. Then we see, it depends on how severe the anemia is, what is the stage of CKD, how symptomatic the patient is. Then we decide how to treat, whether oral supplementation is enough, whether IV iron is required, whether erythropoietin stimulating agents are required, whether blood transfusion is required. And especially when anemia is disproportionate to your CKD, the patient is stage CKD 1, but anemia is 6. So it is not related to kidney. So they definitely need extensive evaluation, like whether any GI bleeding is there, when any malignancy is there, or any multiple myeloma is there. So this is how we approach a patient. Oral iron supplementations, like sir said, ferric pyrophosphate is usually well tolerated compared to ferric ascorbate, but it depends on a lot of factors, like individualize. We have to individualize, because our CKD patients or diabetics, hypertensions will be usually on multiple drugs. So they'll be having nausea, loss of appetite, and sometimes they might not tolerate oral iron. So depending, like I said, how symptomatic they are, how severe their anemia is, how bad their iron profile is, we choose whether it oral supplementation or IV iron or blood transfusion or erythropoietin. And depending on the reports, how to, and targets, we usually keep more than 10 grams in non-dialysis patients, and in dialysis patients, 11 grams. Because anything more than that has not shown any benefits in any of the studies compared to uncontrolled hypertension or vascular access problems if you have too much hemoglobin also. So we usually target a hemoglobin of 11.
Ma'am, thank you for that point-to-point discussion on the questions asked. I request others, if they have any questions, please post your questions on the chat box while I continue the discussion with Dr. Sindhu. Ma'am, one thing that I remember from the days of medicine is these RAS blockades, they also prevent progression of chronic kidney disease. And for a patient who is well tolerating his ARB, the telmisartan, which he's taking, and whose blood pressure is well controlled, and who apparently is doesn't seem to be having any significant renal dysfunction symptoms or issues. I agree with the point that we have to stop ARB, but once stop, then restarting, for particularly for a patient whose creatinine is 1.8 or 2, it becomes quite challenging or kind of gutsy. And I believe once it is stopped, it can never be restarted. So what are the stakes and stakes of continuing versus stopping? And do you think it is really possible practically to restart ARBs once it is stopped?
Yes. So usually AC inhibitors, ARBs, both are equally effective, but AC inhibitors, they have bit this cough as a major side effect. So most, especially me, I usually use ARBs only. So restarting is definitely, we have stopped when there is raise in creatinine. See, sometimes patient might be in a clinical situation might be different. He might be having an acute kidney injury where we are supposed to stop the drug. So once he settles, we reassess him and definitely restart. So usually as per guidelines also, you start with a lower dose. For example, anything, for example, you take telmisartan, you start with 20 mg. You reassess him after 2 to 4 weeks to see if he's tolerating it or not in terms of BP, in terms of EGFR change, in terms of hyperkalemia. So if his BP is controlled, see, sometimes from nephrology point of view, we might start it for proteinuric effect rather than BP, like in some conditions like IgA nephropathy, for example, where patient might be proteinuric but not hypertensive. Still, ARB is recommended as an anti-proteinuric effect. So then to target that proteinuria, we keep on raising the dose till patient tolerates it. Like he doesn't have any hypotension, doesn't have any significant raise in creatinine, doesn't have any hyperkalemia. We then go at 40. Then whatever guidelines, KDIGO also suggests that whenever you increase the dose, like from 22, I'm making 40, 42, I'm making 80, then also you have to check after 4 weeks whether the patient is tolerating it or not, or he's having any side effects in terms of BP, GFR, and creatinine. I recently had one patient, since you asked, he was on olmesartan trio combination with cilnidipine and hydrochlorothiazide. He just came for routine checkup. He did a creatinine. His baseline was 1.3. It went up to 2.5. Urine normal, no painkillers. Patient absolutely normal, no infection, nothing. I just stopped the triple combination and I just changed it to cilnidipine and Prolomed for BP control. After 4 weeks, his creat came down to 1.3. Now I reintroduced Telma 20 again. So it depends on clinical situation. There is nothing like we can't restart. Sometimes what happens is renal artery stenosis. When they have renal artery stenosis, sometimes you're increasing ARBs, they might not tolerate it. Then you have to suspect if he's having any, whether he's having any underlying renal artery stenosis. And like I said, sir, Telma is antiproteinuric because it reduces the intraglomerular hypertension. Yes, it's definitely recommended. And like up to 30 GFR, we use it. So beyond 30, stage 4, stage 5, like in stage 5 dialysis, yes, refractory hypertension, he's already on 5 groups of drugs, 6 groups of drugs, not getting controlled. Like Anoop sir said, yes, I'm confident potassium is taken care because he's coming for regular dialysis. Yes, we still go. Otherwise, in between that 3 to 4 stage, it depends. If patient is stable, no hyperkalemia, I don't mind it continuing. But usually beyond 30, the benefits will come down and risk will go up, like hyperkalemias. Especially, like I said, if patient is not in regular follow-up, I've seen some patients coming with complete heart blocks. So it's, yeah, you can definitely restart it, but we have to give some time to the kidney to recoup back and then restart and start at a smaller dose, reassess, make sure he's not having side effects, then increase it. So we usually don't go beyond 80, whether it is BP or antiproteinuric effect. Maximum dose we use is 80, telmisartan 80, olmesartan till 40. Because we get usually hyperkalemias. Potassium goes up beyond 5.5. Sometimes we try to combine with the diuretic to see if his potassium is settling. Sometimes with K-bind, if nothing is working, we have no option but to stop the drug.
Yes, ma'am. There's a question from Anoop. For patients with chronic kidney disease needing angiogram and PCI, should we do both the procedures in the same setting or give a gap from a CKD viewpoint?
Very good, relevant question. This week, our cardiologists keep asking us every day. So regarding this procedure related, like any contrast nephropathy, there are 2 aspects, patient related risk factors and procedure related risk factors. So this procedure related risk factors, what they say is, usually prevent back-to-back exposure to contrast. Subsequent back-to-back, don't do it back-to-back, just give gap or finish it off in the same setting. So you're doing CAG today, giving 2 days gap, again angio, it's usually they say avoid back-to-back contrast exposures. And roughly what they say, roughly there is a thing that if your GFR is 30, for example, you use your volume of contrast less than 2 times. For example, 30 means 30 into 2, 60. Usually use 60 ml contrast. I think cardiologists might not agree with him. Sometimes difficult lesions and all, they might go up. But they say either do it in same setting or give good gap, not like back to back. Frequent contrast exposure is not recommended.
Yes, ma'am. So the normal, the usual amount of contrast used for a diagnostic test, diagnostic coronary angiogram, will be close to 20 to 30 ml, and for an angioplasty, it is about 150 to 200. If you are careful, you might end up in 100. But with the usage of intravascular imaging, particularly intravascular ultrasound, where when we are eliminating frequent contrast injections, we can reduce the amount of contrast. But in general, most of the time, because this is the expensive, intravascular ultrasound is not used frequently. So we do end up using a large volume of contrast, but point taken. Anoop mentioned about 3 times the GFR seems to be a standard algorithm as a max contrast allowed. Other than hydration, any preventive strategy to prevent CIN?
Basically, hydration is the only proven thing, sir. Normal saline, 3 to 3 hours before procedure, intra procedure, and 6 hours post. And other than that, we usually try to avoid this AC. There are no strong recommendations that we have to stop AC inhibitors or ARBs. But we generally, to be on the safe side, we stop. No painkillers should be given. Make sure he's not dehydrated. If you can minimize on diuretic, unless he's in pulmonary edema or heart failure, minimize on the IV diuretic. Hydration is the only one, and not even NSTL system, because especially IV NSTL system, it has anaphylaxis reactions, cost and all. So oral NSTL system also no role, but there is no harm in oral NSTL system. So sometimes cardiologists, they use it, but we don't ask them to stop or don't ask them to start. Main thing is dehydration. Main thing is hydration. Make sure you're not giving any other nephrotoxic drugs, and use Visipic.
Ma'am, any role of prophylactic bicarbonate and a few of these combinations of, you mentioned about NSC, but sometimes this combination of taurine and other drugs, which are again...
Yes, sir, that's what I'm telling. All the latest guidelines on this contrast nephropathy after all the studies, NSTL 16 IV definitely no. Oral you can give, it has no harm. It's not that costly also, but it has no proven benefit. Mainly hydration, the volume of contrast and the type of contrast. Anoop sir, yeah, regarding this holding RAS, see, sometimes holding diuretic, sometimes patient might have STEMI, he might be in pulmonary edema where we cannot stop diuretics. So that otherwise, if a patient is in stable condition where he's on oral diuretics, actually he's not in failure, he's clinically dry, we have to definitely hold the diuretics. RAS inhibitors guidelines, they say need not stop, but me as a nephrologist, I think stopping for 3 to 4 days is not causing any great harm also. So I usually stop ACE inhibitors, ARBs, pre-contrast, and after reassessing, make sure that he doesn't have any AKI, then we can restart the RAS inhibitors. We have many times we have patients with STEMI who are in pulmonary edema who will be on Lasix infusion or IV diuretics. We can't stop diuretics in them because we have to decongest the heart. Then otherwise, stable patient, yes, definitely we can stop the diuretics.
Ma'am, other question regarding role of ferritin or iron studies in managing anemia in ESRD. For getting the EPO injections as well.
Definitely, we do baseline iron studies, sir. If like Shankar sir said, if your TSAT is more than 30 or your ferritin is more than 500, no role for iron, just go for erythropoietin. If iron deficiency is there, like your TSAT is low, your ferritin is less, definitely iron is needed even for erythropoiesis. Even if you give EPO injection, if iron is not there, your response will not be good. So you have to do iron studies, and depending on the severity of deficiency, we reassess them. We give IV iron, do again after 3 months. If it is fine, just go with erythropoietin. We think if TSAT is again less than 30 or ferritin is not that high, we can give IV iron regularly. Sometimes we give, depending on the affordability. Now this latest molecules, this pericarboxymaltose, this iron isomaltoside, they're safer molecules, bit costly, but they are safer than your regular iron sucrose. So definitely we have to do ferritin and iron studies. If required, IV iron has to be given before erythropoietin, and depending on the severity of anemia or severity of this iron deficiency, we have to reassess the patient, do studies again after 3 months.
Yes, ma'am. We are almost reaching 9 o'clock, so I'll take comments from Dr. Somraj sir. Sir, your comments on the discussion and anything that we have missed. Somraj sir. I think he's not available. Yeah, Shankar sir, do you have anything to add?
Only thing is, apart from this diabetes and the hypertension management, it is apt to discuss regarding the CKD management also. Especially, I would like to ask Dr. Sindhu highlight regarding the mineral bone disease and what is the effect of addition of this soda bicarb and the ketonologues and the prebiotics and the probiotics. Can you highlight these things in addition to what we discussed in a brief? Dr. Somraju sir is there. He should be unmuted, I think.
Yeah, no, I think his audio seems to be not connected. The video seems to be on, but the audio seems to be not connected.
Dr. Sindhu is there?
Sir, yes, sir. Sorry, I just got disconnected.
Regarding mineral bone disease, just give a brief note on mineral bone disease. The addition of recent these ketonologues and the prebiotics and the probiotics. Then as mentioned, the taurine and the N-acetylcysteine and all.
Sir, you are asking about our business.
Praneeth, can you hear me?
Yes, sir. Yes, sir. I can.
Yes, sir. We can hear you, sir. We can hear you, sir.
Yeah, I just wanted to say it's a wonderful discussion. Dr. Sindhu, I think she was so exhaustive and so relevant. I knew her father. And when we were very young, and you were the police officer, Dr. Sindhu?
No, sir. No, sir.
Oh, it's different, probably. Okay. It was a nice discussion. I enjoyed and learned a lot of things. I just wanted to say something like, the one thing I wanted to also ask some of you participating is these patients who are on chronic renal failure and dialysis and also on AV fistulae, their diastolic pressures are low, sometimes less than 70 to 50. In patients who have significant coronary artery disease and also this diastolic pressures low, say 50 or so, what is the significance of this in patients who have significant coronary artery disease and low diastolic pressure? That's number one. And if I overheard, Praneeth in the initial presentations mentioned about chlorothalidone in the patient that is presented. I felt chlorothalidone, unless in specific situations, has no role in the initial management of patients with chronic kidney disease. Anything that reduces volume has significant negative issues. And about SGLT2 inhibitors, I have a personal prejudice that these drugs are overrated as an industrial medical complex. First, I just want to know the opinion of some of you on the blood pressure that you have to maintain in patients who are on shunt, AV shunt, and maintenance dialysis, and also significant coronary artery disease. Diastolic pressures are low. Thank you.
Anoop, would you like to take this question?
Praneeth, about diastolic pressure and shunt, I don't think I will have much idea about it. I do know that a lot of these shunts, they are flow dependent. So definitely we do not want the flow to be reduced. And most of the time, those blood pressure medications, they sometimes are adjusted such that the patients, they either skip some of the medications on the day of dialysis or whatnot to give a slightly higher diastolic pressure for them to maintain a good blood flow, something like a 200 ml or something of that sort. But a particular cutoff or a particular comfort zone that needs to be maintained that I'm not quite aware of. I will be happy to get enlightened on that.
Dr. Praneeth and Anoop, the reason why I mentioned is diastolic pressure is the one that drives coronary perfusion. And if you have significant coronary artery disease, a low diastolic pressure with elevated diastolic pressure in the LV is going to create significant problems that has to be kept in mind in managing these patients. Thank you.
Absolutely, sir. I think that that's a very relevant concept. So, to the non-cardiologist in the audience, basically, a lot of what we do in cardiology and to a certain degree what nephrologists do is we work with pressures. We work with the very basic physical principles of how fluid work. And two places where this thing is quite commonly seen is coronary perfusion and cerebral perfusion. So I'll give you an example of coronary perfusion. As we all know that coronaries are perfused maximally during diastole. And the concept of coronary perfusion pressure, CPP, the same thing is for cerebral perfusion pressure as well. So for coronary perfusion pressure, the amount of coronary perfusion pressure that is available, which is diastolic systemic pressure minus left ventricular and diastolic pressure. So that gives you the overall perfusion pressure through which the blood is going to go into the coronary. So lower your systemic diastolic pressure is, or higher your LV and diastolic pressure is, in both the situations, your coronary flow will be reduced, even if there is non-significant coronary artery disease or maybe even mild coronary artery disease. That is one of the reasons why severe AR patients develop ischemia, even in the absence of coronary artery disease. So in the setting of CKD or patients on dialysis, where they have low diastolic pressure, and because of their LVH and high and fluid dynamics, their LV-EDP is typically high, they are getting hit from both the sides. Their diastolic pressure is going down, their LV-EDP is going up. So their overall coronary perfusion becomes much lesser than any other person. So as a cardiologist who deal with some of these pressure dynamics, it definitely is our responsibility to make sure we don't drop diastolic pressure quite low. And that is the reason why when these patients, they come to us, we are a little bit more liberal in managing their hypertension. We don't want their pressures to drop too much. We all know that kidneys also need a slightly higher perfusing pressure. And heart, while it is okay with a mean pressure of around 55, we do not want to drop the coronary perfusion pressure that much. Now, whether we should target a diastolic pressure of 60 or 70 or 80, I don't think that data I have. If something like that is there, I would definitely read and share it with you. But this point is very, very relevant, that we should not drop diastolic pressure beyond a certain point. And truly speaking, IABP works like that only. IABP increases your diastolic pressure and increases your coronary perfusion pressure. So that is one way how IABP works. And the other thing also, what Somaraju sir said, I mean, I'm skeptical about it. I think SGLT2 inhibitors, their expanded use in low GFR cases, particularly less than 30, I personally believe once all the patents are off for SGLT2 inhibitor, we will start getting a lot of data regarding how SGLT2 inhibitors are ineffective in lower GFR, because there will be a new drug to make room for. So I particularly do not prescribe SGLT2 inhibitor beyond GFR of 30. And truly speaking, I become very skeptical even between 30 and 45. Although I do know that the new thought process are coming that you can use SGLT2 inhibitor below 30 also.
Dr. Sindhu, any final comments before we close today's session?
Yes, sir. Two things. Sir, isolated low diastolic pressure, I mean, I'm not that sure, but usually have patients who have low BPs during dialysis. They're more prone for already low BP. They'll be having drop in BP. Every time their BP drops, there'll be myocardial stunning, more risk of getting heart events and vascular thrombosis, frequent inadequate dialysis, vascular access thrombosis. So yes, that is definitely a very, and they don't do well on dialysis. They have very high risk of cardiac events. But like sir asked, isolated low diastolic BP, I'm not sure. And regarding the CKD MBD, sir, like Shankar sir has asked, it starts as early as stage 3, stage 2, stage 3. So we depending on the guidelines are there that exactly when you have to do yearly calcium, phosphorus, vitamin D, PTH and all. But depending on the clinical situation, depending on the stage of GFR or how severe the electrolyte, this calcium phosphorus abnormalities are, we have to address them. We have to monitor them 3 monthly or 6 monthly or annually, depending on things. And then we monitor. Like as I already told, sir, our patients are on multiple medicines. None of these pre-probiotics and alpha keto analogs, they add on to therapy. They have definitely studies where they have shown that gut microbiota alteration, uremic toxins, chronic inflammation, where your pre-probiotics come, they reduce the uremic toxins, they reduce the progression of CKD. But coming to, like Praneeth sir was telling, like coming to clinical practice, sir, it depends. You have to individualize depending on the patient, his affordability. He might be already on too many drugs, antiplatelets, statins, diabetes medicines, antihypertensives, calcium supplementations, phosphorus binders. On top of that, adding pre-probiotics, adding alpha keto analogs. I take it individually, sir, case basis. There is no hard and fast rule. They have proven benefits, but when it comes to real practice, you have to keep in mind so many things, because all these pre-probiotics all these alpha keto analogs are all costly. So even if you write, patient might take it for 2 weeks, then they stop it. So I don't want them to stop the most important drugs which are really beneficial to them. So it depends on case to case basis, sir.
Dr. Sindhu, Dr. Anoop, I just wanted to add, when they say isolated diastolic pressure, we must keep in mind when most of the time it is the nurses who take blood pressure, and occasionally a doctor takes it. The habit of the way we are all trained in taking blood pressure, the moment you reach 80, you take off the stethoscope. And most of the time, diastolic pressures are not properly recorded. You have to keep in mind a significant number of patients with this combination of disorder, with a shunt and renal failure and everything, they have low diastolic pressures. You have to keep in mind and manage them accordingly. Thank you.
Yes, sir. Thank you.
Yeah, so thank you, Dr. Sindhu, for your comments and others also who have participated. Very important points learned about CKD and management of hypertension and diabetes. I think the stoppage of ARBs, stopping of metformin, diuretics and MRA, which can further reduce the volume and can progress CKD, and modification of diabetic medicines to effective DPP-4 inhibitors, SGLT2 with a pinch, and iron supplementation. I think these are all relevant points. So most of the changes were done accordingly. And I will keep a tab on the follow-up of this patient, how is he doing. I think with this, we'll close today's session. We will join you next Wednesday with one more clinical topic. If you have any topic that you would like to discuss, please share with us. Thank you one and all for the discussion and your comments.
Just one last comment I would make.
Yeah.
So this is more cardiology than general, but I would put it in there that each of the specialty, we have our own discrete tools that we can use. One of the tools that cardiologists can use, and they should use, I'm sorry to say that it is not used that frequently, is when we are taking patients up for contrast exposure who are having CKD. A reasonably well-established theory is to do an LV-EDP guided contrast exposure. What I mean by that is, whenever we take a patient with CKD who needs contrast exposure for angiogram or angioplasty or whatnot, a very simple tool that we can use is put a pigtail catheter into LV cavity, measure their LV-EDP, target a EDP of somewhere around 14 or 15. If it is low, then you hydrate on the table, wait for a couple of minutes, make sure the EDP rises up to 14 and 15, and then you give that contrast exposure. If EDP is more than 15, then you can proceed with the procedure and give a little bit of diuretic later on. So I think as a cardiologist, we have this tool available, and it disheartens me to say that at least we see it being used less commonly. It's a very, very simple thing to do. And I urge all my cardiologist colleagues that if you are doing contrast exposure in a patient with CKD, use this tool. It definitely is not going to hurt. And in few patients, you may actually be able to save them from contrast nephropathy. That's it.
So actually, there is one trial, sir, Poseidon trial, contrast nephropathy. He uses that LV-EDP based on that basis only, that study is based on that measurement only, but doesn't it increase invasiveness and cost?
No, absolutely not. If a patient has got a normal aortic valve, it does not increase any kind of invasiveness, and cost is like non-significant at all. It does not add any cost burden. In a modern cath lab where all the equipment are available, it does not add any cost burden. Absolutely not.
Yeah, I think that seems to be a relevant point. I think we should remember this and execute it for the future cases. So I think we are way away from our time. So thank you everyone for your discussion. Good night, everyone. Please take care.